Welcome to the SADS Foundation's 15th webinar in our Living with SADS series. Tonight on ablations and left cardiac sympathetic denervation therapy. It's wonderful to see so many familiar faces and many new ones. I'm Marcia Baker, Program Director for the SADS Foundation. With over 150 people registered for this webinar, it's one of the most popular offered thus far. Before beginning the webinar, a couple of reminders. Please keep your audio muted during the presentations to improve sound quality. Following the two presentations, we have allotted plenty of time for your questions. You may type your questions in the chat anytime during the presentation, and we will address them at the very end. Our webinar is being recorded, and it may be viewed again later by you and others. It's now my pleasure to introduce our two speakers. Dr. Hari Krishna Tandri is an electrophysiologist and co-director of the arrhythmogenic right ventricular dysplasia program at Johns Hopkins Hospital in Baltimore, where he specializes in ventricular arrhythmia ablations. He's been on the faculty at Johns Hopkins for over a decade and is an associate professor of medicine there. Dr. Michael Ackerman is a distinguished physician and researcher at Mayo Clinic in Rochester, Minnesota, where he treats patients and families with various SADS conditions. He is a genetic cardiologist and directs the Windland-Smith-Rice Cardiovascular Genomics Lab at Mayo Clinic. Dr. Ackerman is a professor of medicine, pediatrics, and pharmacology. He also serves as president of the SADS Foundation's Board of Trustees. We are honored that both Drs. Tandri and Ackerman are volunteering their expertise and time with us tonight. So thank you both for sharing your knowledge with the SADS Foundation, patients, and families. We'll hear first from Dr. Tandri, followed by Dr. Ackerman. Dr. Tandri?
Thank you, Marcia. I'd really like to thank the SADS Foundation for having me today give this talk. Let me just say, I'm going to talk mostly about ablation and a bit about sympathectomy in patients with ARVC. As the introduction goes, I'm an associate professor and I'm a co-director of the ARVC program. And most of my expertise in catheter ablation comes from my ablation in ARVC. So I want to give you a little introduction of what right ventricular dysplasia is all about. It's an inherited genetic cardiomyopathy, which predominantly affects the right ventricle. Initially, it was thought to be a purely right ventricular myopathy, but now we're realizing that right from the get-go, it's a biventricular disease with more predominant involvement of the right side of the heart. One of the key features of this disease is that there's a very high prevalence of arrhythmias, and most of the arrhythmias seem to come from the right ventricle. Pathologically, there seems to be fibrosis and fatty replacement of the right ventricle, and the diagnosis is a little bit tricky and uses a complex task force criteria, and you need to really meet many of the criteria based on your ECG, having a Holter monitor, and also imaging criteria to make the diagnosis. So sometimes early in the course of the disease, making the diagnosis of ARVC may be a little bit tricky. What's also interesting is that most patients with ARVC tend to be high-level athletes and kind of present at very young age with ventricular arrhythmias, and occasionally it results in a ventricular fibrillation and sudden cardiac arrest as the first presenting symptom of ARVC. Now, VT is a very common presentation in ARVC. It's often one of the first presentations that patients come in with. Many times it's basically PVCs or having runs of palpitations that usually patients come in with, and sometimes it's basically patients present with syncope because of ventricular fibrillation or sustained ventricular tachycardia. Now, what really causes ventricular tachycardia in ARVC? And there are two phases of this disease, and both have a different approach in management. Early in the course of the disease, especially young teenage type of population with ARVC, there's a very high prevalence of rapid VT. The VTs often are over 200 beats a minute, sometimes really, really rapid, what we call a ventricular flutter. And often the onset of these VTs is during exercise or during the washout phase of the exercise. You just have a severe amount of exertion, and as you're as your catecholamine levels are coming down, it's called a washout, and that's where these arrhythmias tend to occur. And in this stage, beta blockers tend to be very highly effective in reducing the PVC burden and also reducing the risk of sudden death. But as time goes on with this disease, there is scar replacement of the right ventricle. And as you can see, here's an epicardial map that we created using what's called electroanatomic mapping, where we actually take a catheter and measure the electrical activity of the heart. You can see large amounts of scar in the right side of the heart. And at this point, what happens is you develop what's called scar-mediated reentry, where the electrical impulse starts to go around large areas of scar tissue and causes arrhythmias. And in this particular stage, antiarrhythmic drugs or catheter ablation is very effective in treating the arrhythmias. Now, another note about early ARVC here is a Holter monitor in a patient with ARVC, and what it does is basically collects the number of PVCs per hour, and we've collected it over several days. As you can see, we've collected it over 7 days, and in this Holter, what you can see is that all these white bars represent the PVCs, and the white represents the daytime and the black represents the nighttime. As you can see that PVCs are predominantly during the wakeful time. Usually during nighttime, usually there are no PVCs, but as you start to wake up, the PVCs start to get more and more. And it's really driven by adrenaline. And once you wake up and patients start to exercise or do physical activity, that's when these PVCs appear. This has some bearing to the therapies that we actually recommend in patients with early ARVC. What's also interesting is that when we use a high dose adrenaline, a catecholamine infusion, what you start to see is a lot of arrhythmias. And this is one of this very distinguishing feature of this condition, where when you infuse what we infuse called isoproterenol, which is an analog of adrenaline, they start to develop a lot of ectopy, a lot of ectopic beats. And sometimes it results in development of sustained ventricular arrhythmia as well. This feature is not unique to ARVC, but very highly suggestive in patients who apparently appear to have structurally normal hearts with very minimal structural problems, or when you actually test them with high-dose catecholamine infusion, you can make a diagnosis or exclude the diagnosis as well of ARVC in select cases. Now, there are several phases in which people present. It's not like one phase slowly progresses to the other, but people present in various different stages of the disease based on the type of genetic mutation that they have. But what's very common, the common denominator for all of these different stages, is the presence of scar right underneath the tricuspid valve, which is the right-sided valve, which separates the right atrium and the right ventricle. So here is a map of the ventricle from the outside, the epicardial map, and here's the tricuspid valve right here. And often we see this red area of scar tissue right around the tricuspid valve. That's usually seen in earliest forms of disease. But as patients present with more and more scarring, the scarring tends to involve most of the right ventricle. Although left ventricle appears to be spared, there's some involvement of the lateral aspect or the apical aspect of the left ventricle in certain mutations. Now, coming to ablation in ARVC, what are the indications for ablation in ARVC? When do we actually consider that? When patients have an implantable defibrillator for prevention of sudden cardiac death and develop therapies from the ICD, either it may be multiple pacing therapies that stop the VT or actual delivery of shock therapy that stops the VT, that's when we actually consider a VT ablation. VT ablation is also considered where VT occurs following failure of drug therapy, that you treated the patient with medical therapy, but still continue to have occasional episodes of ATP terminated or a shock terminated VT. The other indications are patients who have incessant ventricular tachycardia. In these sort of situations, you may not want the defibrillator to intervene because that would result in multiple shocks. And occasionally, patients who have frequent premature ventricular contractions or extra beats from the ventricle with symptoms associated with it. They also are considered for ventricular tachycardia ablation. Now, some of the important nuances of VT ablation and ARVC is that the circuits of VT often tend to reside outside the heart. That's what we call the epicardial surface. It's not something that you can approach through the blood vessels going through the vein or the artery, but it's something that you have to get on top of the heart. It's basically get an epicardial approach where you actually go from the skin straight onto the top of the heart. It's important because that is where you will be able to identify these VT circuits and ablate them or cure them with very minimal cauterization or ablation. And second thing, these arrhythmias are very sensitive to adrenaline. So sometimes you have a lot of arrhythmias, but then you take them to the operating room and you sedate them and you have no arrhythmias. And you basically cannot find anything because you didn't prepare mentally that these patients actually have adrenaline sensitives. You may actually have to elicit these arrhythmias with a lot of adrenaline infusion or even keep them mildly awake to make that diagnosis. So what exactly is causing their problems? What's also unique is that multiple VTs are not uncommon. So patients present with one arrhythmia, but then when you actually go to perform the ablation, you see that patients have multiple arrhythmias using the same kind of scar. And often, although the scar pattern, as we understand, is very predictable, that makes it ablation is kind of easier because you know exactly how the scar is going to look. Many patients need more than one procedure because of one is that the epicardial surface is protected with a lot of fat, so it's often difficult to deliver heat energy through fat tissue. And the second, you may not present all the arrhythmias during your first ablation. Sometimes you do an ablation and you realize that there are more arrhythmias when the patient wakes up, and probably in a few weeks later, some of the arrhythmia pops up. So it's a possibility that patients may need more than one procedure when they undergo VT ablation. Now, what do we do exactly during a VT ablation? Most often what we do is we understand what the arrhythmia is actually what is causing the symptoms or what is triggering the device. Once after we do that, most commonly it would require an approach where you go outside the heart and map the heart and figure out what is the pattern of scar tissue. And here is a map. This is what we call an RAO view, or right anterior oblique view of the ventricle. This is the entire heart from the outside. This part is the scar tissue. All the purple is healthy tissue. And this is a view which is slightly rotated called the left anterior oblique view. And you can actually see the right ventricle here and the left ventricle here. The left ventricle is predominantly normal. The right ventricle has a scar tissue. And we actually collect a lot of points determining the electrical activity of the outside of the heart. How is the electrical activity propagating through the scar tissue? And it gives us lots of insights into where could the arrhythmia be coming from. So here's actually a map of electrical activity. As you can see in this case, you can see that there is a little bit of a slowing of electrical activity right around this region with the late electrical activity appearing right here. And this we call is late activated regions. And they seem to be most common sites of arrhythmia. And this is where you usually perform the catheter ablation in these patients. This is the same patient I'm showing in the previous one, where we actually identified an area of slow activity around here. And when you actually start to put electrical stimuli into that region, you end up inducing multiple forms of arrhythmias that use the same scar tissue. And so you identify how these things go around within the scar tissue and perform ablations, which are pretty much roadblocks for this electrical activity to propagate, which stops the arrhythmia and makes it non-inducible. There have been several studies looking at the success of catheter ablation, and they've uniformly, come up with one thing. First of all, catheter ablation appears to be pretty safe in ARVC. Most patients are very young, they're very athletic, they have a normal left ventricular function, They tend to be reasonably healthy from other standpoint. They don't have patients usually don't have diabetes or renal failure or anything like that. So in general, they tolerate these procedures quite well. And we published our data a long time ago in patients with ARVC, and we also looked at endocardial and epicardial ablations. And overall, it appears that the acute success rate is over 90%. But however, at about 1 year time point, about 30% of these patients would recur with some form of ventricular arrhythmias. More recently, we published clinical outcomes of catheter ablation in our registry. And this is purely insights from our program. And this is still online only. It's about 116 patients who are undergone 166 radiofrequency ablation procedures. About 106 of them involve the epicardial approach that I mentioned to you. This would be, I think this is online, but will soon be in press. What we found out was that the majority of patients, about 83% of them, require only one procedure, but there are few patients who require more than one procedure, some requiring many into control of VT, and thank God it's actually a small number when it comes to 4 or 5, but most of the patients actually get better with a single ablation, catheter ablation procedure. How have things changed, or how have our understanding changed in the last several years? Just you look at it, here is the Hopkins ARVC programs, catheter ablation volumes for ARVC. As you can see, shown in light gray is the endocardial and black is the epicardial ablations. As time went by, the number of epicardial approaches have actually gone up significantly compared to endocardial, because we realized that the actual circuit often resides outside of the heart. That's why it would require that sort of an approach. So we generally tend to do this as a first procedure rather than wait for people who fail an inside heart approach and then go for it. Here is the cumulative VT-free survival of patients with a single procedure. So you undergo a single procedure for catheter ablation. What happens to you over follow-up? And as you can see, at about 4 years, 50% of them have recurred. So even if you had a single procedure, about 4 years, it's about 50% recurrence rate. But if patients undergo a second procedure, for instance, you had a procedure, within a year, you had another recurrence, you underwent a second procedure. If you count all of that, the VT-free survival is significantly better. And we have follow-ups all the way up to 6 to 8 years, showing that the majority of patients do actually well without any VT recurrences. What's also striking is a reduction in VT burden. If you look at the mean number of events of 10 in these patients, which almost drops down to 0.5 events after the last ablation. So there's a significant reduction in VT burden. For our clinical studies, the appearance of even one episode of VT, which was terminated by the device, either by pacing, is also counted as a failure. So it's a very strict criteria in what we use to determine failure. But if you look at overall how the patients feel after the ablation, you see there's a significant reduction in VT burden. Now, another bonus of doing this catheter ablation is that you get rid of your drugs. So if you look at this and how many patients are on sotalol or amiodarone, if you look at pre and post ablation, there's a substantial reduction in the number of patients who are taking medication, which is a big quality of life issue as well in these patients. Now, I know Dr. Ackerman is going to talk about sympathectomy, but I want to give you a brief introduction of what we have done at Hopkins as far as other things when ablation fails. We've performed sympathectomy, which will be talked in more detail in the next talk, which is a way of denervating the heart, basically taking the sympathetic nerves outside the heart. I've given you a preamble that this condition seems to be very much connected to the sympathetic nervous system. So it's usually precipitated by exercise. If you give adrenaline, their arrhythmias get worse. These are young patients who are athletic and often they have PVCs during the wakeful hours. So it follows that these patients do quite well if they have their sympathetic nerves cut. So this is our patient population who have had several episodes of ventricular tachycardia storms. If you look at these red stars, all these represent multiple therapies for treatment of VT. And if you look at it, these patients actually do quite well. And these are patients who have failed several catheter ablations and anti-arrhythmic drug therapy and still continue to have ICD shocks. Again, if you look at after sympathectomy, there's a significant reduction in antiarrhythmic drug therapy. And not only it helps in the short term, it seems to help even in the long term in patients who have failed multiple ablations and drug therapy. If you do a sympathectomy, they seem to be a long-term benefit as well. And occasionally, patients have a shock or two immediately after sympathectomy because the nerves haven't had the time to completely disappear from the heart. But if you actually look at, if you discount that first blanking period, I think people actually do quite well after sympathectomy, especially this group of patients with ARVC do quite well. So I want to conclude by saying that most ARVC patients respond well to catheter ablation. And in our experience and experience of many other academic programs, catheter ablation is very safe, especially even epicardial ablation seems to be very safe. Beta blockade remains the cornerstone of therapy, given the fact that these arrhythmias tend to be sensitive to adrenaline. Epicardial approach is often needed, and this is often something that's talked about, that often patients get offered and inside the heart ablation approach, the endocardial approach, and if that fails, then you go epicardial. But this is a substrate. This is one of the conditions where you need to go where the arrhythmia is and not just go where you can easily get to. So that's the difference in how you approach this. Repeat procedures are not uncommon, and definitely some patients do need more than one procedure, but they do have a significant reduction in arrhythmia burden. And finally, sympathectomy significantly reduces arrhythmia burden in ARVC, even in patients who fail catheter ablations and antiarrhythmic drug therapy. Thank you. That's our entire team. I'm going to stop sharing right now, and I would let Dr. Ackerman take the stage.
Thanks, Dr. Tandri, and I enjoyed that a lot. I hope everybody else did as much as I did. And to all of you there joining us, it's great to be with you this evening, and thanks for your active partnership with us here at the SADS Foundation. And I'm just going to get my screen activated. And so over the next 15 minutes or so, before we all enter into a conversation together, I'm going to update you about what is the state of this sympathectomy that you heard mentioned by Dr. Tandri, the videoscopic cardiac sympathetic denervation therapy. And I'll focus it on two of the channelopathies of CPVT and long QT syndrome. These are relationships with industry that I have. They don't affect our ability this evening to do this well together. And this well is the following. We'll discuss what is left cardiac sympathetic denervation, what is its role in the treatment of these two entities of CPVT and long QT. And then I'll give you a sense of what are the indications that we've been following for over 10 plus years and what the guidelines have finally caught up to within the last few years. And then give sort of a very transparent expectation of what is the therapeutic efficacy of left cardiac sympathetic denervation. Before we focus on denervation, just a reminder that in our program and others, we try to always emphasize that the channelopathies in general, long QT and CPVT in particular, do not equal a defibrillator. Most of my patients do not need and should not receive a defibrillator. Most of my patients are treated pharmacologically, as many of you probably are, on beta blockers, as you heard, standard of care for ARVD, also first-line therapy for CPVT and long QT, preferably Nadolol, and we can talk in the discussion about what beta blocker does Dr. Tandri prefer in ARVC, which may or may not be the same. We have combination drug therapy in some forms of long QT, and we have combination drug therapy of Nadolol as the beta blocker and flecainide in our patients with CPVT. And juxtaposed between drugs on the left and devices on the right is left cardiac sympathetic denervation, with the left cardiac sympathetic chain shown here, where we have the stellate ganglion shown up here with the head over to the left, and then T2, T3, and T4 in the grabber or the forceps. And when we say cardiac denervation therapy, we have to be very precise. That's exactly what we're talking about, is the removal of that sympathetic chain on block from T4, T3, T2, and as much of the stellate ganglion as you can take, and typically a lower half stelectomy. This is not a new therapy. It's really a rediscovery of an old therapy that's over 100 years old since it was first done. 50 plus years since first done for arrhythmias by Dr. Zipes. 41 years since done for long QT syndrome by the late Arthur Moss and his team. And you see our role, which is having moved it to the minimally invasive videoscopic approach, where we've done more denervation surgeries at Mayo Clinic than anywhere in the world. And I wanted to give you a sneak peek at what does denervation therapy look like. And so you'll see where, just like you need the boutique specialist ablation expert for ablation in ARVC, you need, and maybe in the joy of Zoom, the video won't play. So if not, let me move you to here. This is what you would see if you were the surgeon, Dr. Moyer and Dr. Polides here, where the sympathetic chain on the left side is being exposed and then surgically removed. Why does it work? Essentially, how we think of it is norepinephrine ablation. The left sympathetic chain is the predominant side which secretes the adrenaline chemical, norepinephrine, from the sympathetic chain directly onto the myocardium and makes it agitatable, irritable, electrically excitable. And besides being norepinephrine ablation, it may improve the substrate. Some of our patients, their QTC shortens. I'll give you a couple of stories that show you what its efficacy can be like. In CPVT, this 9-year-old girl, exercise-induced syncope, no doubt about the diagnosis. You put her on the treadmill, things look bad. Wasn't protected well enough on beta blocker, still had a lot of ectopy, and she's now 4 years, actually 6 years, event-free since her denervation. We come to expect this in CPVT. 6 years ago, we published the largest international experience, Peter Schwartz and my program, and you can see before their denervation, the number of events, and then after their denervation, and you can see a marked reduction in events, not elimination. And we have to keep this in mind when you start hearing people talking about denervation being curative. If you ever hear that, run. They're not telling you the truth. A significant antifibrillatory effect in CPVT, extremely effective. How effective? In those who already had bad stuff going on in them, 72% are waiting for a breakthrough event, and an additional 11% have had a marked reduction. So you can see the math, about 15%, we would say the denervation on the left side did not work well enough. What about in long QT syndrome? This is the story, the patient's story. She's an amazing, beautiful person that helped me become a believer in Peter Schwartz's denervation therapy idea. She presented now almost 15 years ago and had a long storyline of breakthrough LQT2 triggered events, no matter what was done, got a defibrillator, had lots of ICD shocks, PTSD was setting in a big way, and then I met her. We offered denervation, and after doing her denervation surgery on the left side, you can see a wonderful result. Compared to a lot, she's had only 3 shocks in the last 12 years since her denervation. The PTSD went away. She's a new woman, and beautiful before, beautiful after, but with a new lease on life. Like these, 1-year-old female, bad LQT3, committed and couldn't get off of lidocaine, and did her denervation, and within 24 hours weaned off the lidocaine, and now 7, 8 years old with only 2 ICD shocks. Now, I show you the best one in LQT3. A word of caution, I'm not convinced that it's very good in LQT3. We do it, but you'll see the data, not that great in LQT3. But it works, and we've known that it works for 17 years with this really important landmark paper from my dear friend Peter Schwartz, which showed before denervation, after denervation, a significant reduction in event rates. We call it the anti-fibrillatory effect. It makes it harder for the long QT heart, the CPVT heart, and as you heard, the ARVC heart to go into the danger rhythm. Here's what we've assembled over the years. You can see the largest in world, which is a good feeling, which means we're learning a lot and we're knowing when to use it, when not to use it. Most of these long QT syndrome, 227, large in CPVT, but then you can also see a large number in the cardiomyopathies. Essentially, any cardiac disease in which it's clear that adrenaline is the trigger, the proximate trigger, the setting, I think unilateral left cardiac sympathetic denervation is going to have a measurable degree of therapeutic efficacy. Who's using it? Who's coming for it? It started in our program, bad disease, please do something about my long QT. I can't take my defibrillator firing anymore. And then a smaller subset, not bad disease, bad treatment. I hate my life on beta blocker. Please do something about that. And I would say now in 2021, at least half of our patients are coming seeking a better quality of life because they don't like the beta blocker so-called zombie effect. In long QT alone, you see a tremendous experience of over 200 plus. You can kind of get a snapshot of the kind of patient who's coming for denervation therapy. And similar to what you saw in CPVT, this is our own single center experience. When we did it for this reason, I hate my life on beta blocker, never a symptom before, still never a symptom after, and liking life a lot better. But in the other ones where they had an event rate that was measurable, you can see a significant reduction, but not elimination. In other words, we say it over and over again, denervation is not a cure. Patient selection is going to be important. And we know that this is not a new pronouncement. If you really look carefully at the original data from Peter, which wasn't commented upon, but you can calculate it, 10% had zero reduction in event rate. We would call them either therapeutic failures or treatment non-responders. And we've been working hard to try to figure out who are the ones who are more likely to break through after their denervation than those who won't have a breakthrough, faint seizure, cardiac arrest, ICD shock. And it's not surprising who are the breakthroughs. Bad disease. So when the disease substrate is really bad, it's simply not a curative anti-fibrillatory effect. It can decrease rates, but we should not expect it to eliminate all events. There's a genotype dependent event on the breakthroughs. It works absolutely the best in LQT1, and we continue to be concerned about its inadequate therapeutic effect in LQT3. It's not perfect in LQT1 either. We've had now 7 as of last week, our 7th LQT1 person who's had an event after their left-sided denervation. And so again, even in the group that it works the best in, LQT1 and CPVT, absolutely the best, it's not curative. We need new therapies for LQT3. Denervation isn't good enough. And when we look at our 10% who are non-responders, just like Peter's from 17 years ago, look at that. The age of diagnosis, infant, first cardiac arrest, 3rd birthday, denervation at 7 years of age, QTC 700, my goodness. So again, when the disease substrate is fully expressive, we still need better therapies than denervation. In a few, we've done right-sided denervation, and we could talk about that in our conversation as when would we go to right-sided denervation, which we just did in an LQT1 individual 4 days ago. So for the last 15 plus years, these have been our indications. One shock, and you should be eligible for denervation. Shock-related PTSD, we're all beginning to realize this, recognize this, and respect it more. It's not enough to say, that's why you got the box, get used to the shock, it did what it was supposed to do. A single shock means I have more work to do to get that patient under better control. I hate my therapy, my medications, or I just broke through my medications. High risk, but not quite there yet, a bridge to an ICD. And satisfyingly, now the official guidelines of all of the leading cardiac societies across the world have recognized denervation therapy with a class 1 indication. And what's really special about this from my standpoint is whether it's CPVT or long QT, it's a class 1, and importantly, it has equipoise with the other therapies. In the past, the mindset was, you will not get denervation until you already have had a defibrillator, and then if the defibrillator shocks, oh, maybe we can give you the denervation. Not any longer. It is on the same playing field where my patient's family and myself, we weigh all of the risks and benefits in the balance, and we get to decide for that patient precision medicine, which therapy, drugs, more of them, devices, denervation, which therapy makes the best sense as our next therapeutic move. And so again, it is fully there, clinically recognized. I heard it said about a week ago that denervation was experimental therapy. Nonsense. It is clinically robust, clinically vetted, and clinically recognized as a class 1 treatment option, class of recommendation, the highest we have in medicine for our patients with long QT and CPVT. So our current indications, now codified by guidelines, are the same as what they've been for 15 years. Now it's the same with societies recognizing it. And we've added a new one uniquely to Mayo Clinic, and it will be, stay tuned, more to be discovered. What about, in the right patient, one-time therapy called denervation monotherapy, long QT syndrome only therapy? I'm not suggesting for CPVT only therapy, but could it be possible that we do a one-time therapy, left-sided denervation, for our long QT patients? And we have 64 such patients that are blazing the trail by their motivation and desire. And almost all of them, you can see, symptomatic prior to diagnosis, only 25%. Symptomatic prior to their denervation, only 8%. So in other words, these aren't bad long QT substrates needing more therapy. These are okay long QT substrates dissatisfied with their quality of life. And here, just published, we've had 3 non-lethal events, now 4 as of last week, in 64 patients on solo therapy. So that's about a 1% chance per year of a non-lethal event rate in this very carefully selected patient. About complications, very few in the right center with the right surgeon and surgical team. And so our first 250 some cases, no arrhythmia badness during surgery, almost never have to convert it to the open approach. We can stay minimally invasive. Horner syndrome is a small number. We've done 1 eyelid lift surgery in our first 320 plus cases. I would like the denervation therapy option even more if we solve the 5 to 10% of our patients who might have a post-denervation neuropathic pain phenomenon that can take weeks and months to resolve. Thankfully, it's only 5 to 10%, but we're trying hard to make that number 5 to 10% even lower. And we think we have some ideas and are seeing some positive trends to lessening the likelihood of that occurring. This is one of the things that is seen, the so-called post-denervation harlequin appearance, which she shared with me and lets me share it with you, with the left side being pale and dry and the right side shimmering in sweat. And nevertheless, despite that and everything else they feel after their denervation, In our study and in the study from Dr. Skinner down under, the patients would choose the denervation over how they felt from their beta blockers. So high scores for quality of life post denervation. I'll leave you with about 5 take-home points, and then Dr. Tandri and I would be delighted to start a conversation with you. Remember, first, that done appropriately and with the right surgeon, it provides a minimally invasive approach with minimal comorbidities. It confers potent antifibrillatory therapy. It's protective and effective as recognized by every major cardiac society. So let's not let the ICD keep firing. For sure, after a single appropriate shock, think denervation. At least think treatment intensification. Don't be settled with the doctor just telling you that's why you got the box. Remember, it's not a cure, and if any person and program is suggesting that it's a curative treatment, run from them. It's not a correct presentation of the data, and as such, patient selection will be key. I just quickly want to acknowledge these entities that continue to support our efforts here at the Mayo Clinic, including the generous philanthropic support from Wendy's family, for which we could not do this without them, and we appreciate their partnership. So I will turn it back to Marcia. Thank you for your attention. And Dr. Tandri and I we know we're looking forward to the next 15 to 20 minutes together.
Well, thank you so much, Dr. Tandri and Dr. Ackerman. And we have a few questions already, some good ones to start with. And as we go through these, feel free to add questions in the chat field for our gentleman to answer. So first of all, let's see, what's the longest follow-up time for a child with a sympathectomy?
Yeah, the longest now, great question, is 40 years, because one of the first denervations done back in 1970 from Arthur Moss's program in Rochester, New York, was in the 70s. So we now have 40 plus year follow-up. Our longest is 16 years. We started our denervation therapy program at Mayo Clinic in 2005. And there we've done it in as young as a 4-week-old. So that 4-week-old infant is now about 12 years old. So that would be our earliest with longest. But the longest out there in the world is probably about a 40-year follow-up, now close to 50 years, actually.
Okay, thank you. And what are the long-term side effects or mortality of a bi-CSD in children?
Well, a great question. We almost never need to do a bilateral sympathectomy. That is our left side and a right side. And we never do both at the same time. Now, that might be a little bit different in the ARVC sympathectomy program. We'll let Dr. Tandri comment on that. My approach is we always start left, unilateral left, and we will intensify if we need to. We almost never need to. So we don't have a lot of bilaterals that we need to follow, but those that we follow with left alone or both, there's the beauty of this denervation is there's no long-term comorbidities of any important organs, none to the heart structurally, none to the lungs, none to the GI tract. The main is the sweating aspect of the left side. It has nothing to do with strength of the left hand, tactile sensation of the left hand. It's just the thermoregulatory sweat fibers. There's a few patients who will have a unique sweat reaction to certain spices, and it's different for different patients. That's uncommon, but we haven't seen, I would say the only comorbidity that I'm annoyed by, because my patients are annoyed by, is the 5 to 10% who are dealing after the denervation surgery with what we call a post-denervation neuropathic pain. And I don't want to sugarcoat that. It's a real 5 to 10%. Those who are enduring it, it's a big, big deal. I think it's getting less. I think we're getting smarter about how to treat it and get in front of the pain to accelerate the healing of the nerve endings. They all get better. And so that's the good news of it. But if you're one of those 5%, the first 3 months after the denervation, you're not necessarily pleased with your decision. And some of them might even take the beta blocker feeling that they had during that window of time while they're going through what they're enduring. Tandri, anything in terms of with your ARVCs, are you starting left and then upgrading, or do you go straight to a bilateral with your ARVC cohort?
Sure, that's a great question. I think our experience comes from literally the UCLA group dealing with structural heart disease and how they started off. And I think by the time we started in 2014, there were already enough literature suggesting that for unilateral left sympathectomy, the success rate was not as good as doing bilateral, especially in the setting of structural heart disease. And this data is mainly from patients with dilated cardiomyopathy, patients with sarcoid and ARVC sort of cohort, not so much ARVC, but mostly from an non-ischemic cardiomyopathy cohort, not from the channelopathies. So we started a program with bilateral sympathectomy. Just to give a little overview of the right and the left seem to have very, very distinct effects on the heart. The left one clearly is more into electrophysiologically changing the refractory periods within the left side of the heart, which means that it actually has a very profound role to play in the QT interval. So as soon as you stimulate the left stellar ganglia, you don't see increase in heart rate, but you see increase in force of contraction of the ventricle and a big change in the QT interval. But the right stellar ganglia literally behaves like an adrenaline infusion. As soon as you stimulate the right stellar ganglia, it's almost like somebody just gave you like a whiff of adrenaline. The heart rate goes up, the blood pressure goes up, and all sorts of things very similar to a rush of adrenaline happens. So they do have this very different effect on the heart. But in structural heart disease, you seem to not want your heart rate to go up anyway. So basically, we do want to pretty much cut out all the sympathetic influences that come from the higher centers down to the heart. And the denervated heart really behaves like a transplanted heart, but just with the vagal connections. So if the vagal connections are intact and you've just cut out the sympathetic nerves. And our experience exclusively at Hopkins has been with bilateral denervation. The only odd occasion where we ended up just doing the left was in a patient where we could not physically do the right because of adhesions or whatever. But in general, I think our approach has always been bilateral cardiac denervation. And again, I agree with Dr. Ackerman. The biggest concern that at least the patients express in the first 6 months to 1 year is this back pain, this annoying neuropathic or neuralgic back pain, which seems to trouble them a lot. But the rest of the side effects are short-lived, especially the ones with a little bit of bleeding, some pneumothorax, and we haven't had any Horner syndrome in our series yet. But I think that's a problem that still remains to be solved. And how do we do this procedure in a way that it relieves patients of this neuropathic pain?
Okay, thank you. Okay, another question. Would let's use the acronym here, LCSD, be recommended for someone whose CPVT symptoms seem to be well controlled with nadolol and flecainide? So would it be recommended for that person? Also,
No.
would this procedure possibly reduce the use of medication or reduce dosage?
Yeah, so two great questions on the CPVT side, and you saw ARVC, yes. So the first part is if the patient with CPVT has a great result from combination drug therapy, nadolol and flecainide. And by a great result, my goal is to cure your stress test. Make your stress test look like my stress test. And if I've achieved that on medications and you're pleased with me, meaning your quality of life on those medications is really good, there's no need to go to triple therapy. When we go to triple therapy is in the person with bad CPVT, where they've already have a defibrillator implanted. I often will go to triple therapy because I want to short circuit the possibility of the defibrillator ever becoming part of the problem in CPVT with an ICD storm. The other place where we go to denervation therapy, Marcia, is in the person, just like you said, I don't like how much beta blocker I'm on. And could we get to less? And so we have several CPVT patients where their treatment program is combination drug therapy, combination therapy, but with the combination being denervation only and flecainide. So a way to make the Nadolol dose lower, and occasionally the Nadolol dose 0. So it all depends on what's driving the patient towards a treatment modification and what the goals are. I wouldn't say that is not standard. That would not be the norm out there in the world, denervation and flecainide as the two-pronged approach. But we've done that and we're very pleased with that in the correct patient.
Okay, thank you very much. Key in for the question. Andrea asks, is a sympathectomy effective in ARVD patients?
Yeah, Tandri, why don't you take that again and we can comment too.
Sure. Again, we have actually performed sympathectomy in ARVC patients and select patients who have actually failed catheter ablation and continue to have ventricular arrhythmias despite antiarrhythmic drug therapy. That was a good place to start because that's usually the place where you all start to take the most high-risk patients where we have exhausted all therapies and do them. But as things progress, now we're actually opening it up to patients who have failed a one catheter ablation, patients who actually demonstrate exercise-induced arrhythmias, clearly very adrenaline-mediated arrhythmias, and it seems to really work quite well. And given the fact that these patients mostly are very young, athletic, and they seem to tolerate the procedure quite well, they're out of the hospital the next day or the following day very quickly without any issues with the surgery itself, and they seem to have a lot of benefit from it. And I haven't really had anyone complain about that sympathectomy has actually resulted in them, a reduction in quality of life. It's always been that they've avoided ICD therapies, have avoided, a reduction, definitely have had a reduction in antiarrhythmic drug therapy, which has significantly improved their quality of life. So I'm a strong believer in ARVC, which has a lot of overlap with CPVT, significant amount of overlap with CPVT. Both look like exactly the same things, one with the structural problem in addition to it. So I think in the right type of patient in ARVC, sympathectomy has a big role to play in reduction of antiarrhythmic drug therapy, reduction of ICD shocks, and also improving quality of life.
Dr. Tandri, if I could ask, we both said that beta blocker therapy is first line, front line in all three of our diseases. I mentioned that when I say beta blocker, I like to say as in Nadolol, and if not Nadolol, propranolol. But is Nadolol the preferred beta blocker in ARVC in your program? Or when you say beta blocker, are you referring to a drug that is beta blocker plus?
So that's a great question. Again, we started from two different angles trying to approach this. In cardiomyopathy in general, metoprolol seems to be the most commonly used drug, like in patients with LV disease and ischemic cardiomyopathy and so on. So our experience in starting off with metoprolol has been quite, well established in patients who deal with adult cardiomyopathic patients. So we start with we have patients who are on Nadolol, we have patients who are on bisoprolol and other different drugs, but our preferred drug has been metoprolol or carvedilol in patients who actually have left ventricular dysfunction in addition to significant RV dysfunction in patients in ARVC. And again, similar problem, most patients don't tolerate beta blockers at all. So we really have a lot of struggle even in uptitrating the dose or even coming up close to what is recommended in cardiomyopathy, in the field of cardiomyopathy, as far as the appropriate dose that has been studied in clinical trials.
Okay, thank you. So Heather would be interested in hearing more about the rationale for dual sympathectomy versus right-sided only for ARVDC patients.
That's an interesting question. The right-sided sympathectomy, as I mentioned to you, right-sided sympathectomy is what you would do to particularly affect the right atrial ganglionated plexus. That's the right stellar ganglion, seems to have a profound effect on the sinus node. So, and also the right atrial, electrophysiology, and of course the AV nodal conduction as well. So what it would basically do if you just do a right-sided sympathectomy, probably have some effect on your peak maximum heart rate that you can achieve. But it doesn't do a whole lot to the electrophysiology of the heart in a way that it is antiarrhythmic. Then most of these antiarrhythmics have an effect on conduction velocity, have an effect on how quickly the heart recovers or how slick it actually gets. Right side doesn't seem to have a whole lot of effect at that level. So our understanding of the efficacy of sympathectomy on reducing arrhythmias comes from mostly the left stellar denervation, especially as the whole history goes. That's where we started. And right was added on as an afterthought in patients with structural heart disease, in addition to left, when the left stellar ganglion alone sympathectomy did not result in the desired effect on reduction of arrhythmia burden. So in general, we tend to do the left and the right, because there is some degree of compensation that can occur if right stellar ganglion, right sympathetic chain is left alone in these patients. Although this is still a work in progress, we're still understanding, should we do T1, T2, T3, and T4? We should just do T1 and T2. Where do these actual nerves come from? And all of these fine tuning is still work in progress, and still right now, it's still done by the surgical colleagues. We're trying to see, can we do it minimally invasively? Can you do more selective denervation of the heart, not just denervate everything? So all of these are work in progress, but as it stands today, we are testing clinically bilateral sympathetic denervation in patients with structural heart disease.
And the only thing I would add there importantly is, I think like Dr. Tandri mentioned, we're learning a lot, but I would say anybody who's young should never get a bilateral up front. We should be thinking about this as a dose response curve. We know that the vast majority of the norepinephrine chemical that tricks the LV heart to get irritable comes from the left chain. And that's true in 90 to 95% of dogs, probably true in 90 to 95% of humans. And so we always start with the unilateral left, and then sometimes we have to do a dose response increase and either take out the 10% of norepinephrine that's coming out of the right chain, or in that unusual individual where the right chain is carrying the majority of that noradrenaline to the heart muscle, not to the SA node that Dr. Tandri was speaking of, but to the muscle, then we need to add the right sympathectomy. One of the things that will be a really nice advance, but there's no way to do it yet, is can we learn before we do the surgery which chain, the left chain or the right chain, is the dominant norepinephrine secreting chain? And so that's why we always start on the left. And we even do that in our program with the ARVC young people. Now, if you are older and fragile, we agree completely in the ARVC to go bilateral up front. But if you are young, healthy, without cardiomyopathy, pump weakness, and it's mainly an electrical disease for which the agitation is clearly exercised, we would always advocate starting left. Can always bring them back and do the right, just like you could always bring them back and do an ablation. Now, there was a really important question that came in while I was talking. I want to make sure we don't miss it for Dr. Tandri. Is I said that a long QT patient, CPVT patient, who gets a shock, that one shock is enough to get denervation. Completely agree. I still agree with myself. But I don't want you to think that one shock with ARVC should send you to denervation. I think Dr. Tandri will tell you that one shock from your ARVC substrate should have somebody thinking about ablation as the intervention of choice after that first ICD shock, rather than denervation as the first treatment of choice in the shocked ARVC person. Dr. Tandri, would you agree, expand?
Sure. So I view all of these as, different levels of therapy that you can provide. There's a level of therapy that you can provide to the whole body, which is the antiarrhythmic drugs that you use. You can basically provide a level which is selective to the heart, where we actually do a catheter ablation. And there's a level that's at the neurologic level, basically provide a level of, sympathetic denervation. And it's not like one size fits all. So if you go in there and if I map the ventricle and I see it's a nest, it's a harness nest, I keep inducing VT5, VT6, VT8, and I do a catheter ablation and I come out shaking my head saying, no, this is not going away. She's going to come back, or he's going to come back with another shock. And I go tell them, get a sympathectomy, because I know you're going to be in the same predicament in a month from now. Right. So, but I go in there, it's a clean kill. I see it. It's a perfect circuit. I ablate it. It's gone. I come out as a success. So there's a lot more that goes into our decision making on what is right for you. And this is exactly goes back to what Dr. Ackerman said. It's all patient specific. It's really a tailored therapy that we come up for each subject with a broad overview of these are the therapies that are available for you, for us, for our disposal, but then we can tailor it for each individual patient. So, so there are patients where I've gone in and come out and said, no, this is not going to work. Another ablation is not an answer. But there are patients who I say, just get an ablation, you're done.
Okay. Dina asks Dr. Ackerman, is there any pushback from insurance companies, considering all the major heart orgs are supportive?
A great question. Depends on the insurance plan.
Mm-hmm.
Most no. So the pushback, I would say overall, is less and less. My batting average, if I speak to a human being and I challenge them and say, if this were your child or you would be coming here for the denervation surgery, wouldn't you? So I think you should change your answer for the person you're insuring. And there, the batting average is 100%. And that's a little bit rigged because I refuse to accept no as an answer from the insurance company. So we battle and battle them. Pleasantly, those kind of battles have gotten less and less. The pre-approval rate, without me having to call anybody or enlighten anybody, I would say is probably 80 to 90%. And we have patients who come all over the country, so representing a wide variety of insurance plans. So the insurance reimbursement landscape is overall quite good.
Okay, thank you. What's the difference between ventricular tachycardia and PVCS?
I can take the question.
Okay.
Ventricular tachycardia really is a definition where you have a rhythm from the lower chamber of the heart that's fast, because tachycardia literally over 100 beats a minute, and it sustains, where it goes into you at least have at least 30 seconds of this rhythm, the persistent fast rhythm coming from the lower chamber. PVCs are generally extra beats. They're isolated. They can happen in the middle of your normal rhythm. They can have isolated beats of extra beats coming from the lower chamber. Those are called PVCs. Sometimes these two are tightly connected. These PVCs sometimes do cause the ventricular tachycardia, but for distinction of something that's a nuisance, sometimes just these PVCs to a ventricular tachycardia, which is a more dangerous rhythm. That's how we make the distinction between those two entities.
Okay, thank you. Henry asks, thank you for the length of follow-up after sympathectomy, but in the long term, greater than 5 years, what cardiac changes are you finding? Does myopathies worsen and more transplants compared to controls?
Yeah, so I'll take it for unilateral left. When you do what the majority, the most common denervation, when we say denervation therapy, that's what we're really meaning for the channelopathies, unilateral left, just the left chain. We still get an echo, which means we're still wasting insurance companies' money probably. The reason I say that is because there was a notion put out probably 2-3 decades ago that when you remove the left sympathetic chain, and you heard Dr. Tandri mention the left chain and contractility, that might mean that when you remove that chain, the muscle will get weaker over time. And it turns out there's zero evidence for that in humans. So we get echoes now we've decreased them, but we get them in the first year after denervation, probably 3 years out, 5 years out, 10 years out, and then we stop unless there's a symptom that changes. And we've actually never seen a decrease in contractility or pump function. We also don't see any impairment in the motor, meaning the heart-lung engine can get up to high octane levels in the athlete after denervation compared to him or her before denervation. So with unilateral left, we're not seeing any signal of a weakening effect over time with the muscle pump. And I suspect that at some point in time, we probably need to decrease the frequency of the echo surveillance test. That's a $2,000 test every time somebody does that ultrasound. And we probably don't need to be doing that surveillance that often any longer, even at 1 year, 3 year, 5 year, 10 year. I think the evidence is pretty clear that it doesn't hurt the pump function of the heart.
I want to follow up that by saying that it's basically, think of it as a transplanted heart. No nerves, take it from one person, put it to the other person. It's not going to connect with your body. It is denervated. The heart function remains pristine, unless you're rejecting. It's a completely different problem. This is not it's a accompaniment of denervation per se, but it's something to do with having a different organ in your body. But there is really no change in ventricular function, and patients with transplant do really well. They do quite well. So in that sense, it doesn't seem to be that these nerves fundamentally dictate heart function. They can make it slick. They can add, fine tune it. They can make you a Ferrari, but for all practical purposes, you can be a Honda Civic. It doesn't matter. Like you can get from point A to point B. You can do all the functions of your life without any interruption, without these nerves. But it's clear that when you need to have an arrhythmia, you need these nerves to make the heart slicker. Without that, you cannot fibrillate the heart. So that's an important thing. Transplanted hearts don't fibrillate because you need the nerves to coordinate that action and make everybody synchronously misbehave. And that's what fibrillation is all about. So I think there is definitely a benefit to having these nerves in a very archaic and a primitive environment where people had to fight for survival. But right now with a diseased heart, it seems like it's a mischief to have these intact nerves and have all the adrenaline.
Okay, thank you. Dr. Tandri, here's another one for you from Carol. Must one wean off of a beta blocker, metoprolol or amiodarone before having an ablation? And if so, how far ahead?
So that's a great question. The problem with either the metoprolol or the amiodarone is that most often patients are anxious when they come in for an ablation. It's often not possible for me to say, oh, hold it for 2 weeks or whatever. And most of these ablations tend to happen in the setting of somebody just getting shocked or having a rhythmic episode and whatnot. And this is kind of the wrong time to wean those off before they come to the ablation. So there's so much of anxiety associated with people coming, and often people travel from out of state to get these done. So my recommendation has always been to, if you're on amiodarone, at least stop for like 4 days or whatever. Patients come in town and they're actually here, and then they stop the amiodarone and they come in. It's not that every bit of it is outside, but if there is a circuit, I can usually induce it in the lab by creating the right circumstances. Beta blockers are usually stop about 24 hours, and that's more than enough for stopping the beta blockers for ablation.
Okay, thank you. And I think one final question here. How do you map the electrical transmission in the heart in the diagnosis phase for endocardium?
So if I probably would read the question correctly, it was looking, how do you map the heart in the diagnosis phase? And we have done this in patients where the diagnosis has been really tricky on, in most of these patients with ARVC or any structural heart disease, a good assessment of the electrical activity of the heart by doing an ECG, a Holter, and good assessment of the imaging by an MRI tells you the whole story along with the history. But in some patients, the diagnosis is very challenging, tricky. There may be some minor abnormalities that are kind of matched with the ARVC, but then we're not really sure. In those cases, we actually go through the femoral vein and go into the right ventricle and actually literally use a high density mapping catheter to touch the myocardium and collect the electrical signals from there. And a normal myocardium, right ventricular myocardium, has a voltage of about 5 to 10 millivolts or about. And often when you come to areas of disease, you actually see that there is very low voltage along with presence of scar tissue. And the pattern in which that scar tissue is distributed in the heart gives you the story of what exactly this is. And as I told you, the presence of the scar right underneath the tricuspid valve in that specific location kind of gives away that this could be the diagnosis. And along with that, we also give them a lot of adrenaline during the procedure to provoke these arrhythmias, which doesn't happen in a structurally normal heart. So using all of these, we kind of decide how to do this, how to diagnose the substrate, whether it is sarcoid, ARVC, or something else we're dealing with.
Okay, Dr. Ackerman, Heather asked, can a sympathectomy allow one to have their ICD removed?
Well, Heather, so we finish our program, I think, with an easy question. No, that's a great question, Heather, and it's a really hard one. It's a really good one. And I would say the short answer is yes, but it depends a lot. And what I mean by it depends on why did that person get their defibrillator in the first place. So for example, if I saw the patient and I never thought they should have gotten the defibrillator in the first place, and I like how they're treated without denervation, I don't need to add denervation to then get rid of their defibrillator. Meaning I don't feel beholden to continue with somebody's decision to install a defibrillator if I didn't agree with that. And the didn't agree with it might mean that was well-intentioned, but old news, old data, wrong interpretation, but they were more aggressive, or somebody just wasn't current in their thinking, or somebody was ICD slap happy, meaning, if you see a nail, get out the sledgehammer. And now we know that most patients don't really need a defibrillator. So if that was the scenario, yeah, I don't need the denervation at all to then remove the defibrillator. Now, where we are starting to see this is in CPVT, for example. We're trying harder and harder not to install defibrillators, even in cardiac arrest survivors. And so that person, we might have him, if that was a cardiac arrest survivor, CPVT person with a defibrillator on triple therapy besides nadolol flecainide denervation. And over the course of the defibrillators, 7, 8, 9, 10 years, all we've had is problems from the ICD. When that defibrillator is up for renewal, we may not continue that renewal. And so it really will depend on what's been the risk-benefit package of that safety device. Has it provided efficacy, peace of mind, protection without ICD baggage? Great. If so, we're likely to keep it in play. If it's been nothing but a problem ever since it was installed and we wouldn't have installed it anyway, then we're working to get that person eventually to an ICD-free treatment path.
Okay, thank you very much. I'd like to thank Dr. Tandri and Dr. Ackerman for their time and sharing their knowledge tonight. And I want to thank all of you for joining us. As we said, this is recorded, so if you want to miss any part of it or want to share it with friends and colleagues, you may do so. So thank you all for tonight. Appreciate all the wonderful information and the great questions that came forward.
And Marcia, if I could just add a quick word of thanks to you. Thanks for this family webinar series that you've been charged with. You've done an amazing job with all of them. Thanks to Aaron, thanks to the SADS team. And I personally want to thank Dr. Tandri for joining us tonight. Appreciate you, Hare Krishna. Thanks for everything for the families. You're amazing. And I am so thankful for each of you. If you haven't been joining us on Fridays for SADS Facebook Live, join us a week from this Friday, June 25th. Not long QT, not CPVT, not ARVC, but I'll be joined by a dear friend, Sammy Biskin from Israel talking about all things Brugada syndrome. And so if you know of somebody where that's relevant, let them know. Stay connected to us at the SADS Foundation. We're here for you, and we'd love to hear from you. So good night, everybody. And Marcia, keep up the amazing job. Thank you.
Thank you,
Thank
Dr.
you.
Ackerman.
Thanks a lot.
Thank you all.
Thank you.
Good night.
Good night.